Good evening, everyone, and welcome to tonight's webinar. My name is Adam, and I'll be your moderator. This webinar is part of our Breaking Down Barriers to Care webinar series. Our mission with this series is to shine light on areas of dentistry that are overlooked by many and increase awareness to help achieve optimal oral health care, which is a critical component to achieving good overall health. If anyone would like to view past Breaking Down Barriers webinars, click the link in your related content widget. We're excited to welcome Dr. David Reznik as our speaker tonight. Dr. Reznik is director of the Grady Health System's Infectious Disease Program and the star of our COVID-19 and dentistry webinar series. Tonight, he'll be discussing treating dental patients with HIV. If during the webinar anyone has questions, please feel free to type them into the Have a Question box, and we'll do some live Q&A at the end of the webinar. And lastly, we are offering CE credit for tonight's webinar. If you're interested in receiving your CE credit, there's an icon in your control panel and on your screen. Click that icon and complete the short questionnaire, and you will receive a follow-up email within 24 hours to receive your credit. If you have any questions about CE, please email webinars@henryschein.com. Dr. Reznik, thank you so much for participating in this series and covering tonight's topic. Looking forward to it.
Well, thank you, Adam, and thank everyone for joining us tonight. It's actually a pleasure for me to talk about this topic. Some of you might know me for the COVID-19 webinars that Adam talked about earlier, but literally I've been working in HIV oral health for a few decades, maybe 3 or plus. So I've been doing this for my career. This is what I do on a daily basis. And I really want to share some of this information so we can increase access and reduce barriers to care, and hopefully get rid of some of the false messages you might hear or still hear on occasion about treating this patient population. So with that being said, let's get started. First, I am receiving a financial contribution from Henry Schein Dental for this webinar. That's my disclosure. And what are we going to be talking about? So we're looking at some current trends in epidemiology of HIV disease, understand the role of oral health in diagnosis and care of patients with HIV, review post-exposure management, discuss dental treatment considerations. What is it that I have done differently for 37 years, and then I would do for a person who didn't have HIV? And where are we? And today is a really important day to talk about this because it's National HIV Testing Day. It's one of the days that we have during the course of the year where you bring focus onto an important issue. So I think a lot of people have heard of World AIDS Day. That's December 1st. But National HIV Testing Awareness Day is truly important. And it's even more important this year. And the reason being, during the first year of COVID, during when many of us were working from home or we weren't working or whatever the situation was going, it impacted routine health care. So some people weren't getting mammograms. Some people weren't getting the GI tests that they needed to have done. And a lot of people were missing regular testing. And that happened with HIV as well. We found out from CDC data that in healthcare institutions on CDC funds, there was a 43% reduction in tests in 2019 and 2020 compared to the year before. So we saw a marked decrease there, a 50% decrease in CBOs or HIV organizations that they were doing testing. So there was a significant reduction in testing. And knowing your status is the number one way that we can control this disease. We have come a remarkably long way. This disease was first recognized in 1981. I will say that I was in dental school at a remarkable dental school. I never heard anything about HIV while in school. And I graduated in 84. So that gives you an idea. So this disease was so new, nobody really knew the cause. We actually came up with multiple names for this disease. At one point, we knew the syndrome before we knew the cause. And so this has really come a long way. But if you look at this, between October and May of 1981, there were 5 young gay men who were treated for a biopsy-confirmed pneumocystis carinii pneumonia, a specific pneumonia that we now know as an AIDS-defining condition. This occurred at 3 different hospitals in Los Angeles. 2 of the patients died. All 5 patients had laboratory-confirmed CMV infection and candidal mucosal infection. So they had oral thrush. And as oral healthcare providers, we do oral exams on every patient that we see. There are no oral manifestations that are actually diagnostic of HIV, but they can sure give you a hint that someone needs to be tested. And we'll cover that in our next webinar next month. On July 3rd of 1981, there were 26 additional cases. And December 10th in 1981, there were 3 new papers describing this. At this point, HIV was a death sentence. It is no longer that. HIV is a chronic condition that people have. We can literally get virus to an undetectable level. We can get the virus so under control that people cannot transmit it sexually. So the advances that we have seen, we have gone from a disease where death and dying was routine. And as dental healthcare professionals, we were not trained for that. And up until around 1996, 1997, and in Georgia, we were a little slow. We were seeing, in my patient population, we could have 400 to 500 deaths a year, which was remarkable. Now we still have 100 preventable deaths a year, but they are preventable, which is, I think, also key. We now have a national HIV/AIDS strategy, and we have some vision and goals that go through it. We really need to have a clear response to this disease. It has been 40 plus years now. And look at the advances that we have made with vaccines and things around COVID in 2 years, and we still don't have a vaccine for HIV at this particular point. What's sort of fascinating is that the technology, the mRNA technology, is what we're looking at now for vaccines to treat or prevent HIV. But when we talk about the strategy, the United States will be a place where new HIV infections are prevented. Every person knows their status, which is what's so key on HIV testing day. And every person with HIV has high quality care and treatment, lives free of stigma and discrimination, and can achieve their full potential for health and well-being across the lifespan. The main driver of this pandemic has been stigma in the United States. If we can get past the stigma and discrimination, we can really get to a place where we will have an AIDS-free generation. The vision includes all people, regardless of age, sex, gender identity, sexual orientation, race, ethnicity, religion, disability, geographic location, which is really important because the large majority of the cases now are located in, of course, your big states, which we're talking about, but also in the Southeast, or socioeconomic circumstance. So we have this wonderful program called the Ryan White HIV/AIDS program. It was initially called the Ryan White Care Act. It was passed in 1990. It was funded in 1991, and it provides access to all kinds of primary care and access to medications. But if you look at the legislation, you'll see access to treatment, access to antiretroviral therapy, and then access to oral health care. So we've been advocating. I know there's some people on the call who are truly great advocates of making sure that oral health care always stayed as a need for this patient population. The strategy does set some bold targets for ending the HIV epidemic in the United States by 2030. And as far as I'm concerned, that would be a blessing. It includes a 75% reduction in new HIV infections by 2025 and a 90% reduction by 2030. We really want to be a 90-90-90. Prevent 90% of new infections, have 90% linked to care, and have 90% with undetectable viral load. So it really does guide the vision towards preventing new infections, improving HIV health-related outcomes, and reduce HIV-related disparities and health inequities, which we are still seeing today, and achieve integrated, coordinated efforts that address the HIV epidemic amongst all partners and stakeholders, which is why I'm so glad that we're putting on this presentation for you tonight. If you look at the rates of HIV positivity per 100,000 in the United States, if you look at the darker red or almost a burgundy, those where you have the highest HIV positivity rates in the US. So you can see that there's an issue with New York and California and Nevada and Texas. Almost all of the high states, to be frankly honest, are located right now in the Southeast. And we'll talk a little bit about that. But New York still has a problem. It hasn't gone away in many of the states. And when you see the really white areas, there aren't, no offense, but there aren't a lot of people in those states. So you can see that Texas has an issue, Louisiana, Mississippi, Georgia, South Carolina, et cetera, et cetera. So if we look at AMFAR, which is one of our research organizations, in 2019, nearly 1.2, actually today, nearly 1.2 people in the United States are living with HIV, and approximately 13% do not know their status. And why is that so important on HIV testing day, which should be every day? If you know your status, you're significantly less likely to put somebody at risk, up to 70%. If you know your status and are linked to care, we can get you on antiretroviral therapy, which will make you unable to transmit this disease sexually. If you know your status, you get in care, you live a full lifespan. Now, there are some concerns about aging in HIV because about 50% of all the cases of HIV today are aged 50 and above. So aging with HIV brings its whole nother situation of issues that we need to look at. I can say I'm aging without HIV, and I've had a lot of things that I'm dealing with, so I can't imagine what it would be like. For every 100 people with diagnosed HIV in the United States in 2019, 76% received some HIV care, 58% were retained in care, and 66% were virally suppressed. So when I say virally suppressed, what I'm really talking about is they have undetectable viral load. The 58% retained in care is an awfully low number. And that's another role that we, as a part of the primary care team, and I strongly believe that as dentists, dental hygienists, people who work in the dental field, we are part of primary health care. You cannot be healthy without oral health. So we can follow up with our patients. When was the last time that you saw your medical provider? Do you know your viral load? Do you know your CD4 count? What medications are you on? Just the normal health questions that you would ask any patient who comes in about whether diabetes status, cardiovascular health, etc. We always want to update that medical history. Now we're really working on medical dental integration so we can just get this information and work as one unit. But 58% retained in care is not good enough. And so anything that we can do to help our patients overcome barriers to care and stay retained in care is a plus, an added addition to what fabulous services that dental health care providers give every year. There are 36,000, almost 37,000 new HIV diagnoses in 2019. I will show you how this chart goes in a little bit, but the chart isn't going down fast enough. We've been around 41,000 cases for far too long, and we need to get these numbers to go down. In 2019, southern states, that's where I live. I am from Atlanta, Georgia. Actually, Marietta, Georgia. I work in Atlanta at Grady Health System, one of the largest public health hospital systems in the country. And I will give it a little plug here. We built a community-driven program that follows close to 6,000 people with HIV, 2/3 of which have advanced HIV or stage 3 HIV, what we commonly refer to as AIDS. We offer all services under one roof. We have primary care. We have pharmacy on site. We have a Center for Well-Being, which is mental health and substance use issues. We have a brand new state-of-the-art 12-chair oral health center that I am remarkably proud of. We have a treatment and holding unit where we do outpatient chemotherapy or can stabilize people who have fallen out of care and do a direct admit to the hospital if need be. We have peer navigators. We have social services, case management, and not enough because there isn't enough funds, but we have case management services. We have a family, women, and children's center in our program because at the beginning, a lot of the women did not want to be around a lot of the men, which is where they got their infection. So we really have tried to listen to the community and create a program that will address our community. African Americans account for 42% of HIV diagnoses in 2019, although they comprise only about 13 to 14% of the population. That has got to end, and that's something that we all need to concentrate on. In 2019, there were 15,815 deaths amongst people diagnosed with HIV in the U.S. in dependent areas. These deaths may be due to any cause. So it's just like somebody, let's go back to a COVID for a second. Somebody might be diagnosed upon admission to a hospital with COVID, but the reason they're at the hospital is they're having chest pain or they're having difficulty breathing not related to COVID, et cetera, et cetera. So there are multiple reasons, but still losing almost 16,000 people is far too many. Looking at gay and bisexual men, of the nearly 37,000 new cases in the U.S. in dependent areas in 2019, almost 70% were among men who have sex with men. In 2019, about an estimated 755,000 gay and bisexual men were living with HIV. About 13% of them were unaware of their status. Again, if you're unaware of their status, you haven't been tested, one, your health is going to go down pretty quickly. Two, you could infect others without knowing it. The object is to know your status. Everyone in the United States ages 13 to 64, and I think that number should really be higher since I'm getting there, should know their status and be tested at least once. If you're at risk for the infection, say that you are an African American or a gay man who is having sex with men, then you might want to test more frequently. The whole idea is to know your status. That's the first step and the most important step. African American, gay, and bisexual men account for the largest number of HIV diagnoses, but right underneath them are Caucasian men who have sex with men. There just are more Caucasian men who have sex with men. From 2015 to 2019, HIV diagnosis decreased 9% amongst gay and bisexual men overall. So we're starting to see a good trend, not good enough, but a good trend, and remains stable for African American and Latino gay and bisexual men. That was actually important because those numbers had been increasing and on a steady state. So to see that they had remained level means or stable means that not good enough, but we're making progress. And that's sometimes all we can do is make progress. HIV in women. Approximately 22% of people living with HIV in the United States are women. About 1 in 10 are unaware of their status. So again, that it's the same thing here. We need to let women know that they're vulnerable. In my program at Grady, about 27% of our patient population are women. Adult and adolescent women account for approximately 20% of new HIV diagnoses in 2018. 85% were attributed to heterosexual sex, or I actually read a paper recently that said intercourse, which was sort of interesting, and 15% to injection drug use. From 2014 to 18, HIV diagnosis amongst women declined 7% overall, going in the right direction. New HIV diagnosis declined 10% amongst African American women and 9% among Latinas. And that is really where the importance is, because the majority of the cases that we have in my program are amongst African American women. We do have some Caucasian women in our program as well, but that was an area that we really needed to target. We needed people to know their status to protect themselves. New HIV diagnosis, but there was an increase amongst 15% amongst Caucasian women, and that's a relatively small number, but a high percentage. So everybody who could be at risk, and we just need to take steps to protect ourselves. Know your status. If you're heterosexual, you're in a steady relationship, test once. Know your status, you've met the requirement. Among women diagnosed with HIV in 2018, 57% were African American, 21% were Caucasian, and 18% were Hispanic or Latina. So it's still showing up in all populations, just disproportionately showing up in African American women. For every 100 women diagnosed with HIV in 2018, 76 received some kind of care, 58% were retained, and 63% were virally suppressed, about the same number that we saw just a moment ago in men. HIV in young people. Youth aged 13 to 24 accounted for more than 20% of the new diagnoses in 2018. Young men accounted for 87% of new HIV diagnosis among youth in 2018, young women for about 13%. About 92% of young men acquired HIV through male-to-male sexual contact, about 85% of young women through heterosexual contact, just like in older women. These numbers are actually somewhat horrifying. Among people aged 13 to 24, an estimated 44% of those living with HIV at the end of 2016 did not know they were infected. It's been a long time since I've been a youth, but I do remember when you're young, you feel invulnerable. It's not going to affect me. That's infecting these people over 50 in these large cities. I'll be frankly honest, when HIV first hit in Atlanta, when I was actually not even in Atlanta, when I was reading about it in New York and Los Angeles and San Francisco, I thought, well, that's something that's infecting these 45-year-old people, these gay men that were 45 and they lived in these big cities, and well, it's not hitting us down south. Well, it might not have hit us at the time down south, but it surely is hitting us now. Youth with HIV are least likely of any age group to be linked to care in a timely manner and have a suppressed viral load. Only 30% of youth living with HIV in 2016 were virally suppressed. So it really does take special effort when you're talking about an adolescent population. And so what we have done in our program was we've actually extended our youth and adolescent program to cover people ages up to age 24. Because once you go from the adolescent program, which has more social services, has more case management, you're going into the adult clinic, which doesn't depend as much on those services. So the handoff between adolescent to adult care is truly important. And we have to make some changes into how we schedule. If adolescents aren't showing up at 8 o'clock in the morning for an appointment, they're more likely to show up in the afternoon, then let's schedule them in the afternoon. If we know which big nights are possibly late nights during the middle of the week, then we don't want to schedule early in the morning the next day. We have to meet our patients where they are. People with untreated HIV transmitted 80% of new infections. 15% who did not know their status accounted for 38% of new cases. 23% who knew their status but were not in care accounted for 43% of their cases. So if you look at these numbers, 81% of the new cases were either caused by people who didn't know their status, did not have an HIV test, or who knew their status, but for whatever reasons were not retained in care. So again, retention in care is an important component. Identification that someone might be at risk is something that we can do, as I mentioned, and we'll cover oral manifestations on the next month. But you can see some of these oral lesions, none of which are diagnostic of HIV, but why would a 24-year-old person show up with candidiasis? It could be because of using a steroid inhaler and not rinsing out. I love our medical colleagues, but when they write these steroid inhalers, they really don't stress the importance of rinsing out afterwards, a role that we can play. or it could be undiagnosed or uncontrolled diabetes or even early onset diabetes. And we know that we have an issue in the United States with diabetes. So there are other things that can be due to, say, something like pseudomembranous candidiasis, but you can't rule out HIV. And that's the point where we can do certain different things. We can do HIV screening as a part of routine dental care. And I know some wonderful programs, a specific program that a friend of mine in a kinder in Wyoming, who's head of public health in Casper, Wyoming, and I did technical assistance for in Kansas City, where they are still to this day doing routine HIV screening as a part of dental care. And that is remarkable. So they might not, if you look at healthcare settings, federally qualified health centers, there are a lot of people who go to the dental side of the facility, but never go to the medical side. And so there's opportunities for us to find out systemic illnesses that are impacting our patients and our quality of life and to link them back to care. 11% in care but not virally suppressed accounted for 20% of new cases. And the medications that we have today are truly remarkable, with high barriers to become resistant to. So there's even a new medication that is getting ready to go in front of the FDA in the relatively near future that would treat people who are heavily resistant with 2 injections a year. So we've gone from people who are taking handfuls of pills multiple times a day, some with food, some without food, to now 1 pill once a day. We now have shots that are FDA approved that could be 1 shot once a month or 1 shot every 2 months. So now we're looking at something where it could be 1 shot every 6 months to maintain an undetectable viral load and to live a long and happy life. It's not saying these medications don't have side effects. There are side effects to these medications, but then again, we're not seeing the side effects that we saw before. There were some really physical changes that we saw, something called buffalo hump. You'd see remarkable levels of xerostomia. Yes, we still have some xerostomia in this patient population, but not nearly what we saw before. 51% who were virally suppressed accounted for 0 new cases. That's probably the most important line I'm going to say tonight. It's called U equals U. If you're undetectable, it's untransmissible. And that really is where we need to be today. When we talk about our plan to end HIV, yes, HIV infection started to stabilize in 2013, but that is not an overly impressive chart to me. If you look at the x-axis, you can see that, look at the area between 40 and 42,000, and you can look at the y-axis between 2010 and 2016. There's not a lot of change. This is not, as far as I'm concerned, we still are not where we need to be. That chart needs to be going in this direction. We need to be at a point where we're taking care of people who are already infected and not really at a point where we have these new infections, close to 40,000 new infections a year. It's got to stop. So what is the plan to end HIV? We want to diagnose all people with HIV as early as possible after infection. We want to treat the infection rapidly and effectively to achieve sustained viral suppression. So for in our program, if you test positive and you show up, we want to get you in care that day. We want to get you in medications that day so we can start getting your viral load under control. We want to protect people at risk for HIV using potent and proven prevention interventions, including pre-exposure prophylaxis, a medication or medications that can prevent HIV infection. So we actually have a little blue pill, not the blue pill you might be thinking of, but a little blue pill called Truvada, and there's even a generic of it now that is 93% effective in preventing sexual transmission of HIV. We have an injection that can prevent HIV infection. We have other things that we can do to protect ourselves from getting HIV infection. So let's take advantage of this remarkable science. So if you're doing a new patient intake, And you look at the patient and it has, do you have HIV or AIDS? And they check no. And you look at your medication list and you see Truvada, which might ring a bell. It's an HIV medication. It's not because they have HIV. They're taking every step to prevent acquiring HIV infection. A great advancement that we have seen during this journey of HIV that many of us, including the Vice President of HIV Dent, Helene Bednarch, and Steve Abel, and Michael Glick, and so many people that I could name, the Greenspans, have done in this field. We want to respond rapidly, detect and respond to growing HIV clusters. You might hear of some of these injection drug use clusters. The last one showed up in West Virginia. We want to be able to see this is going on and go in and take steps to prevent it. And we need an HIV health force to establish local teams to provide care. And that's actually becoming another bit of a concern. Many of the original providers, whether they be nurses, nurse practitioners, physician's assistants, physicians, dentists, dental hygienists, dental assistants, we're getting to the age where we're retiring out. We need to effectively train the next generation of workforce to make sure we have enough people. There are 1.2 million people in our country that are living with HIV, and they need expert care to help provide care. So one of the things that we're doing now is to try to train primary care providers on HIV. But if you think a primary care provider has to worry about pulmonary disease, cardiovascular disease, liver disease, et cetera, we have specialty care in infectious disease, not necessarily just infectious disease, that manages patient population. I've been working in this disease state, as I mentioned, for quite some time. And at this point, I'm beginning to say, all right, I'm not retiring anytime soon, wink, wink, but what am I going to do as far as a plan for succession? Do I need to start thinking about that at this point? And I think many of my colleagues are doing the same thing. We're beginning to age out. I really, truly plan on not retiring at any point, but it will happen at some point. So it's just the same thing. One of my heroes who started the first HIV research in the Southeast, Michael Sag, is not really retired, but he is not doing full-time what he was doing before. Gratefully, our medical directors are at Grady, our Emory professors. We have an executive medical director who has followed up with the chief of medicine was one of our initial medical directors. Now we have a senior medical director, executive director, and I won't say how old she is, and we have a younger medical director. So on the medical side, we're doing a pretty good job in Atlanta, but where are we on the dental side? So everybody on this call, all dentists, dental hygienists should be able to treat this patient population. It really doesn't take expertise. When people say, well, you're an expert in HIV dental care, what does that mean? I don't do anything differently than you do with your patient population on a daily basis. And I think that's also something that's important. So where are the hotspots as far as HIV is concerned? And this is the map with the highest HIV burden. And these are places that receive funding for the End the HIV Epidemic initiative. So you can look and see, yes, New York has an issue. There's an issue in surrounding states. But if you look at the blue states, those are states that have statewide issues. So that is South Carolina, Alabama, Mississippi, et cetera, Oklahoma. And then you look at Florida, where you have multiple metropolitan areas. You have Fort Lauderdale, Miami. You've got Tampa, St. Pete, Clearwater, Orlando, Jacksonville. And in Georgia, it's mostly in the Atlanta metro area. There are 56,000 people living with HIV in Georgia at the moment. You can see there's hotspots in Texas, multiple hotspots in California, and there's Seattle. So these are the areas where you have the highest concentration, but there are a lot of rural cases of HIV. We're trying to travel to an HIV medical provider might be a couple hours. And so we really need to do what we can to reduce or eliminate barriers to care. So these are some of the data sources that I used for the first part of our presentation. Most of it comes from the CDC, which is our excellent partner when it comes to prevention with HIV. And now we're looking at actually a national prevention plan to go along with this that would actually be able to make sure people had access to that medication that can prevent HIV infection. And what's a problem is, again, low resource people have the least access to this medication. Again, we need to find a system that will make sure if you're at risk, you have access to prevention, you have access to care and treatment, you have things that will eliminate barriers to care. The Ryan White HIV/AIDS program has proven to be a remarkable healthcare model. If all of our healthcare was set up the way that Ryan White is set up, then we would have a healthier United States. So what are the impact of oral opportunistic infections in this patient population? The healthy oral cavity, as we all know, because we're on this call, is an integral part to oral health well-being in HIV-infected individuals. And we like to use people first language, so people with HIV. Compromised oral health affects the diet intake of patients, which subsequently leads to nutritional deficiency. Especially now, I think I'm really concerned about where we are with access to foods because of inflation and the cost of foods. So hopefully we have food banks in your area, maybe offered by clinics or offered by churches or offered by AIDS service organizations. Amongst HIV-associated infections, orofacial lesions contribute a major proportion of the opportunistic infections resulting from deteriorated quality of life in patients. And this is something, regretfully, that me and colleagues have been seeing since the beginning of this pandemic. Regretfully, I still have young men coming to our program presenting with Kaposi sarcoma, something that we really shouldn't be seeing today, but they don't think they're at risk. All of a sudden they get tired, they get ill, but they don't come in at that point. They wait until at that point we really need to hospitalize them. They're at stage 3 HIV or they have AIDS. And if we did testing on a routine basis, especially for youth, which are at more risk, we can get people into care way before that happens. Oral lesions may indicate the presence of HIV, but as I mentioned before, they are not diagnostic. Kaposi sarcoma first showed up in older Mediterranean men of Jewish descent. That's about as far away as you can get from an African-American man who has sex with men in the United States. Oral manifestations seen in association with HIV are among clinical manifestations which occur early in the disease state. So if we do our oral exam, we see a biomarker that might be suggestive of HIV. If you're not doing HIV screening as a part of routine care, and your dental, at least have a place that you can refer for someone to say, when was the last time you had HIV test? Everybody aged 13 to 64 should get tested at least once. When were you tested? And that way you're not stigmatizing, you're not judging, you're just encouraging someone to know their status. Oral lesions or oral manifestations reflect the immune status of patients and are mainly associated with a lower CD4 count. Remember, if you have a CD4 count of 200 or less, that's an AIDS-defining condition. So a higher immune CD4 count, less likely to present, but people who present with candidiasis at a higher CD4 count. I remember a case that I had of a patient who had a CD4 count close to 500, relatively normal, had an undetectable viral load, and had one of the worst cases of one of the worst cases of candidiasis I had seen, and it was actually due to overusing steroid inhalers. You know, you have some people that go drug-seeking behavior, looking for narcotics. Apparently, this person was seeking the steroid inhalers because of asthma. It made him very anxious. And so we had to tell him to rinse out afterwards. We had to work with primary care to have him use the steroid inhalers appropriately. And that's what the cause was. It had nothing to do with his HIV status. Factors that predispose an HIV-infected patient from an oral opportunistic infection could be a CD4 count less than 200, as I just mentioned, a viral load that's detectable. And usually when we talk about undetectable viral load, there are two measures. It could be less than 200 copies or less than 50 copies. But if you have a viral load that's 3,000 or more, you're more likely to show up with an oral lesion. Dry mouth, again, another source that's common, and poor oral hygiene. People who are low resource have less access to dental care, and that's something that must be addressed, especially in a state like mine where as soon as you graduate out of Medicaid, if you're an adult male who is very poor, less than 100% of poverty, you still don't qualify for Medicaid. It's very difficult to qualify for Medicaid as a single male in the state of Georgia. Not only that, but for Medicaid eligible adults, the only services that are covered are surgical services, extraction and trauma. So again, there are things that due to differences in access to care that we might see concerns, and how do we make sure that we can improve access to oral health care for all of our populations in the United States. So I'm going to do a case study now, which is hard to do on this medium, but I'm going to try to do it. A 28-year-old HIV-infected male is in need of comprehensive dental care, including 2 extractions, periodontal scaling and root planing, and multiple dental restorations. He initially presents with an acute emergency. He lost a filling, and the reason he lost the filling was that there was decay under the filling, exposing a vital nerve. And here's a picture of this person's oral health, or lack thereof. His medical history: he was diagnosed 3 months ago in the hospital with that pneumocystis pneumonia that I mentioned earlier. That was that first pneumonia that showed up in those cases in 1981. And that's when he was diagnosed in our hospital. He presents with a moderate case of oral pseudomembranous candidiasis at the time of his emergency dental visit to your office. His present medications are Bactrim. That is a medication that we use to prevent this pneumocystis pneumonia. Zithromax, 1 gram a week, which is, remember, if you've seen some old pictures of HIV, you would see disseminated Mycobacterium avium complex. So that was sort of the wasting disease. If you watch some of the movies or you knew people, you would see it. People would get ashy. They would lose a lot of weight. It was really sort of awful. They're not presently on combination antiretroviral therapy, and there's no known allergies. So the history was they were diagnosed in the hospital 3 months ago. They're being treated. They were treated for that. They were released from the hospital. When they come see you, they have a moderate case of thrush. They're taking a few medications to prevent the opportunistic infections, but they're not yet on antiretroviral therapy. Their CD4 count was 50, so that's AIDS. That's a very low CD4 count. Their viral load is off the chart. It's 150,000. Their hemoglobin is 10, so they're slightly anemic. Their platelet count is 75,000, and their absolute neutrophil count are 1,000. Your post test will be on these numbers. Just kidding. So the questions. You're interested in obtaining medical clearance for this patient before you do your work. Which of the following statements are true? Any HIV-infected patient with a CD4 count less than 200, stage 3 HIV, should be pre-medicated prior to invasive dental procedures. So we're going to need to figure out a way to get this patient on pre-medication before we take care of this acute toothache. Candidiasis should be treated prior to initiating dental care to prevent a fungal septicemia or bloodline infection. CD4 count and HIV viral load do not have an impact on the provision of routine or emergent dental care. D, Elective dental work should be postponed if a patient has a detectable HIV viral load. So let's go over these again. Any HIV-infected patient who has a CD4 count less than 200 should be pre-medicated. If they show up with thrush, you have to treat that, because if you don't, you're going to get a bloodline infection. The C number here says if their CD4 count and HIV viral load do not have an impact on the provision of emergent or routine dental care. Or D, elective dental care should be postponed if a patient has a detectable viral load. So these are the numbers that I really would like to, I wish I'd be able to get the audience information on. But most of the time, we see people answering with wrong answers. The wrong answer is A. Any HIV-infected person with a CD4 count less than 200 should be pre-medicated. One of the things that we're working on in dentistry is antibiotic stewardship. There is absolutely no reason that a patient should be pre-medicated solely based on CD4 count prior to invasive dental care. There is no reason to treat candidiasis before you take care of this patient. If I were to do a swab of everybody who works at Grady's infectious disease program, 60% would have Candida albicans culture positive. They just don't have an overgrowth. So no, we don't need to treat the Candida prior to initiating dental care unless the patient's having a difficulty swallowing, and that would be esophageal candidiasis. So you might want to treat esophageal candidiasis before, and we'll talk about that next month. D, elective dental work should be postponed if a patient has a detectable viral load. One, and we'll talk about this, there's never been a documented case of a dental healthcare worker seroconverting after an exposure in the dental setting. And there are steps you need to take, but we've never had a case. So we don't need to put off elective dental care if a patient has a detectable viral load. CD4 count and HIV viral load do not have an impact on the provision of routine or emergent dental care. As I've said in the past or earlier in this presentation, I'm considered an HIV dental expert. I don't do anything different when I treat a patient than when I would be treating my brother, or if I was treating my next door neighbor. I don't know their status, but it's saying they were negative. So there really is nothing different. I do want to know, as part of the healthcare team, how are they doing? Are they adhering to their medication? Do they have a detectable viral load? And there are some labs that are important. That, when you get clearance, that you might want to ask about these questions. Just asking for clearance alone doesn't get you off the hook if there's a problem. So knowing what to ask is really an important point when we're talking about treating our patient population, or this patient population. So, but again, evidence-based research has proven that providing dental care for the vast majority of people with HIV is no different than providing care to the general patient population. I love this study because this study was done before we had combination antiretroviral therapy. At this point, we were moving patients from one drug, they get resistant to the next drug that they would get resistant. We might even put two drugs together and then they would get resistant. So we didn't have the ability to get people to an undetectable viral load at this point. This study, done by Michael Glick and Steve Abel with others, had 331 patients, an average CD4 count of 71, so that's an AIDS-defining condition, and they had 1,800 invasive dental procedures. The number of post-procedural complications was 17, representing an overall complication rate of 0.9%. The incidence of post-procedural complications is no greater with this patient population, with people who have HIV compared to people who don't. So really a very important point that we need to make. Important lab values. Remember, I said it's really important to know what questions to ask. So should we pre-medicate based on CD4 count and viral load? We've already had that answer. The answer is no. Platelet count. Earlier on in the pandemic, we did see a lot of idiopathic thrombocytopenia purpura, or a low platelet count, put in plain English. Dental procedures can be safely performed with a platelet count of 60,000 or above. I've always found this sort of fascinating for oncology patients. It's 50,000 or above. I think a little stigma hit into that number. So that might be a number that you might want to ask. If you have a patient who's on warfarin or Coumadin, doesn't matter their HIV status, you do want to know what their INR is. Actually, I'm blessed. I work in this hospital-based clinic where we can do a stat INR on patients, and that might be a test you might want to look into. Absolute neutrophil count. This is the only time that we would premedicate a patient is if their absolute neutrophil count is less than 500, because then they are more susceptible to infection. People think of HIV in the way that you would think about neutropenia, but it's not. HIV, you can have HIV infection and have a non-undetectable viral load, a low CD4 count, their dental care will be fine. But if their absolute neutrophil count is less than 500, they are more susceptible to getting a post-op complication. Glucose, again, it's really sort of interesting. Greater than 8% is poorly controlled. One, we need people to know their status. Two, doing point of care A1C test is really an important service that we can offer our patients if they don't know their A1C, or doing point of care glucose testing is, again, something that's very important. And these tests are available. There are ways to go through getting the CLIA waiver process and actually perform these tests in your office. When I was out, one of my dental assistants went ahead and actually ordered me a hemoglobin A1C test, which I thought was pretty fabulous. So, how many dental healthcare workers have seroconverted after an exposure in the dental setting? And I've already covered that when I said the number was 0. Since the year 2000, how many healthcare workers have seroconverted after an exposure? And the answer to that question is 1. It was 1 lab tech. So think about orthopedic surgeons, my least favorite. Neurosurgeons, number 2 for me, not my favorite since I've had some back issues. People who are doing different kinds of surgeries. Only 1 person has seroconverted, and that person was a lab person working with concentrated HIV blood. So what do we do if we do have an occupational exposure where there is this National Clinicians Consultation Center, there is a PEP line and PEP guidelines. This slide, I think these presentations will stay online, so this information will be available to you. But what are the chances of an exposure or risk of transmission? So if you think about a needle stick, although our patients think that our needles are, yay long and this wide, compared to medical needles, we have very small amounts of blood that go through. So for percutaneous exposure, it used to be 0.3. We've actually lowered it now to 0.23%. For mucous membrane exposure, something gets in your eyes. Nothing should ever get in your eyes in the dental setting. You should have eye protection on. 0.09%. Cutaneous exposure would have to involve non-intact skin, and it would have to be, again, it's 0.09%. But if you're wearing appropriate PPE, this is not a concern. So we're talking about dental hygienists possibly using a scaler and putting too much pressure, which is why high-speed ultrasonics are so important, but needle sticks. One of my best residents I ever had in my class, within the last 3 months, I saw recapping a needle. The fact that I didn't end up in Grady's stroke center at that moment was a true blessing, because I was so horrified that someone who had been in my program for 9 months would actually do something as such. And people forget and they go back to their normal ways of doing things. So again, we have to eliminate that. So what should happen? And don't do what I did. I had an exposure back in the 80s. I thought I was biopsying KS. I apparently was biopsying my finger. I did everything you shouldn't do. After I did stabilize the patient, at least that was right, I did wash my hands, and then I actually stuck my finger in bleach. I'm going to admit it to you. I didn't know what to do. I squeezed the lesion. I squeezed the plate where I had the stick. Again, when you let go, you get sucked back. So what should you do? Lightly wash the exposed area. Please let somebody know what has occurred. Make sure your office has a system in place. Flush splashes to nose, mouth, and skin with water. I have 3 eye wash stations in my clinic at this point. Irritate eyes with clean water, saline, or sterile irrigants. And please, if you set it up into your city water, make sure that the hot water is turned off. What should be considered potential exposure? For transmission of bloodborne pathogens to occur, an exposure must include infectious body fluids, which are listed here that can transmit. So we had bloodborne pathogens put in place because of HIV. Now we have airborne transmission precautions put in place because of COVID. So literally, when I say the only good thing that's come out of this pandemic so far is that we have really increased our infection control protocols that we use in dentistry, and it's so important that we continue to follow that. Is post-exposure always recommended if the source person is HIV positive? I had a patient who had undetectable viral load. It was a minimal exposure, and I just happened to have one of those blessed days where I went into the medical attending office, because I'm attending in the oral health center, and I had the executive medical director, the medical director, and Carlos Del Rio, who has been quite famous, and you might see him on television. He's actually the Emory Dean at Grady. And I said, should this resident be put on post-exposure prophylaxis, considering minor exposure, a person had undetectable viral load, and all 3 unanimously said yes. So we don't want to be the first program to have someone seroconvert. You don't want to be the first office to have someone seroconvert. Post-exposure is generally not warranted in cases of unknown status, but if you think the person may be at risk, you can do HIV screening as a part of dental care. You could do a rapid test. You could refer to testing, but you should start PEP immediately, post-exposure prophylaxis immediately. And if the person shows up not to be positive, you discontinue therapy. It's most effective when done as soon as possible, and they say that's within 2 hours. Most places, that's not possible. The emergency room is not the best place to get this kind of care. This should be a standard operating procedure on what you do if there is an exposure. Optimal duration is around 4 weeks if tolerated. There is a preferred 3-drug regimen. Truvada, which is that medication I talked about earlier for pre-exposure prophylaxis, is an important player in post-exposure prophylaxis, plus dolutegravir, an integrase inhibitor, or raltegravir, an integrase inhibitor. Both of those medications are very effective. Dolutegravir is only once a day, which is what we are writing these days. If possible, determine the source patient's status, and we don't really worry about the window period anymore, but get them HIV tested if you don't know their status, and that means everybody. I had a patient who was seen in oral surgery. It was a 55-year-old male, African-American male, who had a stroke the year before. They didn't test because they didn't think the individual was at risk. Wrong. You should test somebody if you have an exposure, or have them have a test. So there is this post-exposure quick guideline that is out there that you can follow. They recommend testing at baseline, recommending the exposed provider test can only at 6 weeks and 3 months. This is a great question by Gwen Cohen Brown. Can only physicians prescribe post-exposure prophylaxis? That would be up to your state laws. I don't see any reason, but considering the medical implications and follow-up testing that need to be in place, I would prefer that a physician prescribe. And that's the only time I would ever say that answer. Do you think it's appropriate to ask the patient in which way they contracted the virus in order to access their dental care? No, I do not think it's appropriate to ask how did they get the virus. I don't need to know a person's sexual habits or whether I would like to know if they inject drugs. But no, we don't need to know. All we need to know is that they have the virus and how best to treat them. Another great question. Thank you so much for these questions. They're finally coming in. Because here's the guideline for the National Clinicians Consultation Center. So thank you both, Glenda and Gwen, for your questions. I'll have a few minutes, I hope, to answer a few more. This gives you the hours of the National Consultation Center. And I'm ending with HIV Dent. This is our 25th year that we've been running HIVdent.org or HIV Dental Alliance. We are the organization that advocates for oral health care for people with HIV and have been doing so with my vice president, Helene Bednarz, for the last 25 years. Are there any other questions that might be out there? But I do need to turn this over to Adam quickly so he can give you the important CE information.
Yes, thank you. We do have some time. We are at the hour, but Dr. Reznik covered a lot of information. We will certainly entertain some questions. Go ahead and type them in and have a question box, and we will get to them as we can. And then again, for those of you that are looking for CE credit, we did offer tonight. There's a CE icon on your screen or in your control panel at the bottom. Click that icon, fill out the short questionnaire. You'll get an email within 24 hours to officially present your CE. Okay. I was hoping that would fill enough time.
Is this the time to stump the dentist? No questions?
It is. Dr. Reznik's a great singer, so he can sing to fill the time. All right, you got one.
Why do we not care about CD4 count again? I didn't say we don't care about it. Of course we care about it. We want our patients to have the highest CD4 count. But because a person has a low CD4 count is not a reason to give them pre-medication antibiotic prophylaxis. That is not a reason. And a question, are HIV patients experiencing higher levels of breakthrough COVID infections even after being back? That is a fabulous question. Are HIV patients experiencing higher levels of breakthrough COVID infections even after being vaccinated and boosted? Actually, at this point, the answer is no. We are not seeing higher levels of COVID amongst our HIV positive population. But we are taking every COVID precaution that we were taking 2 years ago. My staff are masked. If you're coming into our clinic, you can be masked. And Helene wants me to mention ultrasonic scaling, which is actually next month, but I can't say no to Helene. It is safe to use a high-speed ultrasonic scaler in a person with uncontrolled or controlled HIV disease. There is no, whereas we're worried about aerosols now because of COVID, there are no cases of a bloodborne pathogen being transmitted via aerosol. Where is PEP readily accessible? Post-exposure prophylaxis is readily accessible at any pharmacy almost in the United States. They will have HIV medications and they will have post-exposure. What you really need to get set up is making sure you have that physician to write it, because you want to do some baseline testing that we really don't do in dentistry. Not only do we want to know their HIV status, we want to know Hep B status, Hep C status, and those sets of labs, liver enzymes, things that are taken that our medical colleagues are better able to handle. These questions keep on coming in. It keeps me on my toes, and also it lets me know what people really want to know.
Yes, we love to play. We love to play a game with Dr. Reznik, Stop the Dentist. So anyone out there who's got questions, don't be shy.
There's been some really great questions. The ultrasonic is always where's PEP and why you should go on post-exposure prophylaxis, learning that there is something called pre-exposure prophylaxis, learning that this is no longer a death sentence, learning that all of us, this is my last year to test to know my status because I'm 64. It's sort of depressing. But that from 13 to 64, you should be tested. And next month, we will cover all the oral lesions. So we'll cover everything from different forms of candidiasis to the cancers that we're seeing today. Talk about Epstein-Barr and oral hair leukoplakia, and I hope you tune in for that.
Yes, great plug. We are back with a part 2 on this topic with Dr. Reznik, July 28th, I believe it is. If you stay on until the end of the webinar, there'll be a little pop-up on your screen where you can register for that directly now, or we will email you after the fact.
Well, thank you for saying I look great for 64. That made my night. Thank you so much.
All right. We will end on that high note there. Thank you all so much for asking all the questions. Thank you for attending, Dr. Reznik. Thank you for sharing this super important information with us. We did record the webinar. Again, the next webinar is July 28th. Stick around. There will be a pop-up on your screen where you can register. We did record the webinar tonight. It'll be available as soon as 30, 60 minutes from now, or we'll send it out to you via email after the fact. That is all I have. Any closing thoughts?
No, I really want to stress that this is a disease that we can't eliminate. It is going to take getting past the stigma, but our job as a part of oral health, this really shows how oral health and medical care work together. My medical colleagues need me to help with the oral manifestations. I might see something that I need help, and medical dental integration is the future of, or the present and the future of where we need to be. And remember, there are things we can do, just not reminding today on National Testing Day to know your status, but for people to know their status. And I think it's really important. There's no reason to be afraid of knowing your status because it's no longer a death sentence. You can live to be old. I am now taking courses in geriatric dental care because, well, that wasn't an issue that I was facing earlier in my career. Now it's something that I need to learn about. So I'm watching some of these webinars with you as well. But thank you for your time and attention. And Adam, it's been a pleasure working with you.
Thank you. Thanks, everyone. Have a great night.